All right. Well, everyone, this is very exciting. This is, well, officially, I guess, the last Wednesday morning NB Heart Center weekly rounds that I'll be organizing. And it's my pleasure to introduce another close friend and a colleague of mine, Dr. Corey Adams. Corey, I've known for years and years and years. He did his undergraduate training here at Dalhousie, and then went on to do a master's at University of Calgary before doing his medical school at Memorial. He did his cardiac surgery training in London at the London Health Sciences Center, and then went on to do a advanced adult valvular heart fellowship at the Bristol Heart Institute. He started working there for a brief period of time before he went on to spend the next formative years of his staff personship at Memorial, and only just recently in 2020 made the move out west to the Libin Cardiovascular Institute of Alberta / University of Calgary. And Corey's a really neat person. I mean, obviously he does everything and he does everything really well. But a couple of things that we share a common interest in are the mitral valve. He's obviously picked up an interest in mitral valvular repair, especially through a minimally invasive approach. He's also initiated the TAVI team out at Memorial and continues to have an ongoing interest in this. And obviously, he's been a kind of a pioneer across the country in terms of trying to really formulate a discussion on infective endocarditis, especially as it relates to IV drug use. So lots of varied interests and just a good all-around person. So I'm really excited that you were able to join us this morning, Corey. For those of you who don't know, it's 5 o'clock in the morning there. And so this is clearly a special ask, and we appreciate the time and your waking up. I know I wouldn't have done it.
Oh, no, well, thanks. Thanks, Ansar. It's a real pleasure to talk with the group in New Brunswick. And just what I thought I would just discuss and just show a video is, I know in New Brunswick and back when I started, when Mark Pelche was there, and continuing with the current group with JF, is just that innovation thought process and about how you can do things better and how we can continue to improve as cardiac care team members. So I think for this talk, what I wanted to say is sort of our transcatheter approach in Calgary and what we've done for some severe mitral annular calcification cases, and what we're looking at doing for some of the degenerative cases. So mitral annular calcification, as all of us in the cardiac care know, this is difficult. It creates a technical challenge. It's more common than we think. And there's degrees of mitral annular calcification. It can be what we would say circumferential. It can be just at the annulus. You can have subannular calcification, but it does require, and it increases the risk of death associated with any form of mitral valve surgery. When we all look at these images together, our cardiologists will often say, we see it on the coronary angiogram. The surgeon will look to see if it's posterior, is it circumferential? And a lot of times, a lot of us have moved towards getting sort of a preoperative CT scan to see how far that mitral annular calcification infiltrates, and to see what we can possibly do in order to correct this surgically. I would say, and the research shows, these patients do worse long-term because of associated comorbidities. Sometimes these patients are your dialysis patients, your renal failure patients, those with radiation. So often the sickest of the very sick patients. And the operation that we propose here from a surgeon standpoint, whether it be en bloc resection, trying to pass your sutures in certain places around the calcium, trying to be creative, atrial sliding plasty. I've never done the left atrial to left ventricular apical conduit, but the other ones I've done all those, and none of them are very good. They're all difficult. They all require a challenge, and they're all left with an extensive pump time, risk of a cerebral vascular injury. They require stitches and work next to the circumflex artery. They have patients that are at risk for atrioventricular dissociation. So, and they do just require that long, extended sort of cardiopulmonary bypass run, risk of a blood transfusion. So when I look at this operation, and it's one of the ones that I spent a lot of time saying, we continue to do the same types of high risk operations, despite knowing that the results are going to be difficult. So from what we focused on and what I've tried to focus on is how can we use new techniques? How can we use our technology, the things that we've advanced, your local expertise to try and think outside the box for this disease and for all diseases. We did the same thing for post-ventricular myocardial infarction VSDs. How can you be creative here? How can we do things better rather than just doing them over and over again in high-risk patients? So my goal here was, given the surgical complexity of mitral annular calcification and the associated patient risk factors, can we at all simplify this operation? And usually people think, well, if you go minimally invasive, that becomes very high risk, and it's not the best answer, but a median sternotomy and the bigger operation. But again, I was trying to think minimally invasive, how can we lower the operative time, less risk for the major comorbidity death outcomes in terms of AV disruption. And also, you want to get your goal here. If our goal is to remove mitral stenosis or take away the regurgitation, then you have to set up that goal. You have to reach the end result. So I just want to run this video. So now we have now done in, so this patient here, and I can stop this as we go and we can come back to it. So this is a right minimally invasive beating heart thoracotomy for a lady in her 80s with severe mitral annular calcification. And I'll take you back just a little bit and we can run this video. So she has a porcelain aorta and was deemed, and it was a real porcelain aorta. Like, I mean, a lot of times we say it isn't, but I didn't feel comfortable that we could actually clamp this aorta. And I'll continue to run it. She had mean gradients of in the 15 to 20 range of her mitral stenosis. And she was a BSA of about 1.6. So we chose a fourth intercostal space. And now here you can see us coming into this here. So I'm in a fourth intercostal space. We cooled the heart down to 28 degrees and we let the heart beat. Now we drain the heart we're on bypass and we're draining our heart. And so we know we've got no ejection based on our arterial line, and we know, and based on the fact that we're empty. Now, as you can see here, what we're going to do is we cut out the anterior leaflet of the mitral valve. So we've done a total of 3 of these now. The first one was not beating heart. So we take this anterior leaflet out. The posterior leaflet on the CT scan, the calcium went right to the back of the heart. This part is new in procedure 3, where we didn't place sutures before, but we were able to get 3 to 4 sutures underneath that anterior leaflet up in A2 with a pledget. And I'll show you why we did that on this one. So preoperatively, she gets a preoperative CT scan, tells us where the calcium is, the coronary angiogram, and access CT scan. So it tells us what the common femoral arteries are like. So I didn't think it was clampable. I wanted to do it with a beating heart, and I didn't think an en bloc resection here or any form of an atrioplasty was going to be acceptable. So now we've got a 29 Sapien 3 valve, and what we've done now is taken a piece of felt, and we just run this along the bottom of the valve. And I just run that felt, or we just run that felt in all the way around. Mark on it in the 3 commissures like you would for a normal mitral valve, just to orientate you where the posts are. Just trying to prevent left ventricular outflow tract obstruction. Now, from our standpoint, we collapse the valve just over. You can see there's no sheath. We just collapse that valve directly down, and you can buttress that up and collapse that any way that you want to. Now, so some techniques, this technique has been done since, goes back to about 2016. Some people use a wire going to the ventricle. I tried that. I didn't find the wire helped. So I don't even have a guiding wire in there. I didn't know where the wire was going because I didn't have fluoro, and I thought it was just a risk. So I was trying to cut down the risk entirely. We passed those 3 to 4 guiding sutures that we were able to get in. I've done this without guiding sutures. These are tourniquets from a cardiac surgery standpoint, just long tourniquets to stabilize the valve. So I bring that valve in. Echo is going to tell me if they see the tip of my catheter. And then I stabilize and balloon infiltrate that valve. So we're snared down on those tourniquets to keep it in place. Just because we were doing it with beating heart this time, I didn't want it to move or eject. And we deployed it relatively high into the atrium to avoid that left ventricular outflow tract issue. Now I tied those guiding sutures, no real reason, and I can't see anyone that why you wouldn't. They're just there with a knot pusher. And I would take, now when I do it again, if I could get those sutures in, 2 to 3 of them, then I would take them. If you can't get them in at all, you don't need them. But I felt a little bit better with them in because we were talked a lot about theoretically the risk of embolization. And that saline test is not great, but it's a bit messy. And now she does pick up speed here a little bit. And then the end result was this. So I just thought I'd leave that video there and we can sort of talk about it a little bit as we go forward. So we were able to do this inside 20 minutes. We were able to, she's extubated the same day. Valve was working great, minimal to trace paravalvular leak. She is very frail, as you can imagine, and she gets over the operation without much difficulty whatsoever. The valve, we've echoed her every 3 months. It did well. She hemolyzed a little bit at first, and she went thrombocytopenic. I think she hemolyzed, but she required a couple transfusions, but it hasn't hemolyzed since. And I don't know if that was just a fresh valve or if it was just the process. But it's not because of a paravalvular leak. We took out this, just to show the video portions again here, we took out the left ventricular outflow tract. To avoid obstruction to the left ventricular outflow tract, because the sapien is large, we do recommend, and everybody recommends, cutting out that anterior leaflet, just to avoid that being pushed down. But I did nothing with the posterior leaflet. And if you can see on this video as we go lower here, I mean, she's got rheumatic fever, or she has a history of it, but there is foreshortening of the subvalvular apparatus. And I didn't touch any of that. I didn't rongeur anything. I didn't make it easier to put in. And that is just a single strip of felt. And you can and there is a rim on this valve where you can actually sew safely. Some people don't use felt, and others have said you probably don't need to, but I think it's an additional way to prevent that paravalvular leak. Do you guys want me to keep running the video? Any questions about the details on the video? We can talk about it as we go, but I thought if it's running, we can.
So a couple of questions, Corey. First of all, so you're basically creating that skirt, sort of, so to speak, that you would see, with some of the, the sutureless valves that we typically use in the aortic position by sewing that piece of felt on.
Completely. Some people don't think that's necessary. So there's been a couple groups that have done this. So the group in Western did it. They placed a annuloplasty band in first, and then brought in a no felt valve. So they didn't put any felt around the whole thing. I kind of thought, well, if you're going to place an annuloplasty band, it means you can probably place sutures. And how bad can the MAC actually be? This is just, so yes, that does serve as a skirt. The group in Mississauga has done it this way, where they've inserted the skirt. They've created a skirt with the felt. They've used 2 layers of felt just to push it up there as best that they can. And the group in St. Mike's, Gianluca Bisleri, was trying to do it, but felt that it was too big on his CT scan.
And then the other question that Chris had is like, how do you size it? And then we should move on because we only have about 7 minutes left or whatever.
Yeah, I go through it. So we'll go through this. So high implants, big risk. I use the felt. I think the guiding sutures are good. Sizing is an issue. That's a 29 cc, and that's up 5 cc's. So what I do, Chris, is they're almost all 3 of ours have been a 29. I sized it with the actual Sorin sizer. There's a 32 millimeter sizer in the OR based on the valve in valve app. If it's a 32 millimeter, then if you were going to do a transcatheter valve in valve, you would use a 29. So I size it grossly in the OR. You can do a pre-op CT, but I'm not sure if area is the best or perimeter is the best. So what we're trying to do is build a series of these. The risk of embolization is real. I mean, I haven't seen it yet. It hasn't moved, but there's no docking station. It's not in place, but maybe with those guiding sutures, it prevents it from embolizing, but we haven't seen any movement yet. And so for this technique,
And just quickly to that effect, Corey, is there a minimum amount of calcium that you need to kind of help hold that valve? Or do you feel like there's just so much in that posterior leaflet anyway, it wouldn't matter?
Yeah, I think there's so much in that posterior leaflet that it wouldn't matter. But I mean, otherwise you're going to do the case. Like this is another one here. So what we're trying at the top. So we're trying to show a series of as many as we can that'll say, look, this is what we've done. We've had good luck with this. If it's not that bad of a MAC, well, then I would just go ahead and do regular surgery. But if you think as a surgeon, well, there's enough that I got to do an en bloc resection or a circumferential or a sliding plasty, then I think you could look towards this. If it's just in one section, a limited, or then I would move on towards saying, listen, I'll just resect that and do the replacement. And so we can talk a little bit about that. But then what I would also say is if you're going to push the limits on mitral angry calcification, how about pushing it on degenerative disease? This is different in my mind. Mitral valve repair for patients with degenerative disease is a much lower risk operation. You're at a 1% mortality. You can go sternotomy, video assisted, you can go robotic, but it doesn't stop innovation. Even if you have a great 1% mortality, I think we still have to continue to say, well, let's push our limits of innovation, because we shouldn't underestimate patient preference. A lot of patients won't want to have surgery and will want to have the most minimally invasive procedure that you possibly can. So again, myself and Bill Kent did a lot of talking about this, is can we improve our surgical management for degenerative MR? And we brainstormed the idea and thought about, well, can we do cases that don't require cardiopulmonary bypass? What about in those high-risk patients that even with a right mini? So we're at about 150 to 180 right minis here per year. But we talked about, can we just be better? I thought this is a nice technique, and we're going to start this at Calgary in the next coming months, and we would have started it earlier. You'll see it come out. The Neocore DS Edwards also has one, the Harpoon. So a transapical artificial cord implant for degenerative mitral regurgitation. So to sort of speed things along, I won't show this video, but the idea here is what they've shown in this with 5-year data in a very small cohort, and is you make a thoracotomy incision just lateral to the left apex. You have you put your sutures in like you would for a VAD to control the apex. Then you can come through with the device that you can see here in the bottom right, sorry. And if you bring it up, you grab the portion of the valve that's degenerative and that's prolapsing under echocardiographic guidance. When you squeeze down, there's 4 little buttons on the device, and it'll tell you if you have good coaptation of that area on the free margin. You then pull that neocord out of the apex, and then you tie the knot on the apex under a beating heart transesophageal echo guided. So you pull the amount of degenerative tissue down. Looking on the echo, you can see if you've got more MR, less MR, and then you tie your knot on the outside. So no annuloplasty band, and you're putting at least, you can put up, they put as many as 5 neocords on this. So we're in the process, and this is the group, so portion of the group out of Leipzig. And my point on this slide is just that they state, well, we can have good success. And the question of, do you need an annuloplasty band when you don't resect tissue, or when you bring this degenerative tissue down into the ventricle and get such a long line of coaptation, do you actually need an annuloplasty? So in this study, and what they talk about is we get good transapical beating heart results of the MR, and they don't believe that they need an annuloplasty because they say we've got such a long line of coaptation and such a good depth of coaptation, which would be a little bit different than the MitraClip. So we'll have to see. So just to sort of wrap this up and sort of carry on a group's conversation is, mitral valve management is complex. I think it requires modalities for surgical treatment. I think, innovation centers like yourself that, we're leaders in TAVI, can focus on this. And I think it becomes an issue whereby you should use the technology that you're good at and try and think about ways outside the box to do this. So we're going to start our Neocore program hopefully in the fall. And we're just gonna go with patients over 80 with degenerative disease that are single segment, single leaflet. And based on the numbers of people we think, based on last year's numbers, that should be about 20 a year. So we're going to try that this fall, and hopefully I'll have some results and some videos for you and how we do it in the future. And that's just it. I just think, in terms of cardiac surgery, the more we study mitral valve disease, the more we know. I agree with Ansar that if you have people that are interested in this disease, sort of like you do with transcatheter valve, we can learn more, we can advance more. And even though we're very good at even degenerative mitral valve surgery, I think there's still many innovative techniques that we should push the limits on and continue to try and improve. And that's it.
Corey, that's fantastic. I don't know if you can maybe just run that video in the background as we talk, the one for the Neocore, and then
I can do that. Yeah.
People can just watch. And then, so a couple of questions. First things first, your screen's a little frozen there, at least for me.
Oh, frozen? Okay, I'll try and come back to it.
Yeah. Anyway, in the meantime, we can still talk to this. So a couple of things. JF had a good question. Well, first of all, the Neocore device, is this I was about to say FDA approved. Is this Health Canada approved?
Need special access right now.
Special access. Okay. And then where does that fall into the grand scheme of things? Because I mean, if you think about it, there's potentially, the competitor would be an already, established TEER or a MitraClip program.
Yeah.
How do those compare?
Yeah. So so in Alberta, MitraClip here is there. I don't know what it is in New Brunswick, but it's 35,500. So per one. Now the way that they're doing that in Alberta is right now, Edmonton had healthcare foundation money to do it. So they're starting the program. We send our patients up to Edmonton for the MitraClip program. MitraClip here at Calgary is not that well received. We push the limits on our right minimally invasive mitral valve patients routinely, even though some are deemed inoperable, they end up going with a right mini. So it's a very aggressive right mini program. So when we looked at it from this standpoint, the Neocore DS is about 20,000, and that's it. There's it's not done in a hybrid OR, it's done in a regular OR, done by our surgical team. So the group here just said, look, if Edmonton was going to start MitraClip for inoperables, who is this group? So this is not, we think that Neocore DS is not going to be for inoperables. We just think it's going to be for high risk. So I think it's going to be the high risk elderly with clear degenerative disease with single leaflet, single segment, that I can probably avoid the pump and maybe keep them out of hospital quicker, but I'm still going to offer that patient a right minimally invasive. So where it fits right now is in Alberta, it's not high risks who go for MitraClip, it's the inoperables. So we're trying to tap into the high risks.
Okay, so sort of that middle spectrum. Question then is around where do you feel like transcatheter mitral valve replacement fits into all of this?
And so I agree. So that's gonna take this. That if you can get a good result with a replacement transcatheter, it's probably less, right? It's probably the way to go if you can do that. But how far are we away from doing that? I mean, I know that Montreal Heart Institute put in a couple. I know there's been a couple done in St. Mike's. We're at least, I think, in Alberta, 3 to 5 years away from offering it to most people, maybe 3 years.
Yeah.
So in my mind, this is a good procedure. Like this doesn't take long. Like I think this isn't, I don't know what a transcatheter how that'll play out, how long that'll be, who's going to do that. Is it better than this procedure? But I can tell you that if we have a leak here, I see it right away. I go back on pump. I can go up another cc. Like this is up 5 cc's. I've gone up as much as 8 cc's. Like I had a paravalvular leak on the last one, came off pump, went up 8 cc's and went up to 8 cc's and ballooned the valve even more, and paravalvular leak's gone.
Yeah. So
this is, I think, a right mini is not that it is invasive, and you can go on pump and all those things, but it's a good procedure.
What about the role for and now I'm talking about mitral annulus calcification specifically, but what about the role for CUSA? So Craig is just asking about it's almost like the calcium rotoblader sort of thing.
Oh yeah. I've never done that. I thought that would be potentially a role there too. I agree. So I've never done it.
Yeah, it's an ultrasonic
Yeah.
decalcification strategy. Yeah. And apparently, yeah, Craig was sort of mentioning in our last rounds about how it may leave behind a reasonable fibrous cap as opposed to, what you expect to see, which is the back of the heart into the pericardium, right? So,
Yeah. Yeah.
yeah,
Yeah.
yeah.
Yeah. I agree. No, I've never used that, but I've seen that. I've seen it on a video, and I thought, yeah, maybe an interesting option.
What's interesting about everything that you're presenting here is the fact that, much like, and then Tavi is serving as a really good basis for all of this, right? Where Tavi has kind of brought together the heart team model. It at least it made it sexy and popular.
Yeah.
Not that it didn't exist before, but it really kind of formalized it, where everybody got into the same room. In our case, we have interventional cardiology, interventional radiology, and surgery. And I feel like, mitral disease, we do that similarly for a mitral clip assessment, but it may be at the point where a lot of these cases start getting discussed by, mitral teams.
Yeah.
And this is a bit of a shameless plug for our upcoming session at the CSCS spring meeting on Friday, which I would love for people to sign up for very cheap, and attend. But I think this is kind of where we're heading to. I mean, we're referring to it as mitral centers of excellence, but the truth of the matter is getting all the same people in the room so you can discuss the 4, 5, 7 different options that exist for these extremely high risk patients.
Yeah, I mean, I agree with that. That's kind of what we do here. I mean, so the majority of the mitral valves go through Bill Kent and I for a minimally invasive approach for isolated mitrals. There's one echocardiographer, if not two, that are interested. And for these cases now at our multidisciplinary team round, someone will say, well, what about if that MAC is so bad? Should one of you guys that have done this, putting the sapien in, try that? And so and then we critique ourselves on this. If you see that picture on the left, that one's lower. So our echocardiographer on that case said, you know what, you do have a bit of a gradient here of about 20 or 30, and that may be too low. So we deployed the next one higher. So it took the expertise of the echocardiographer, who now says, look, I think this is one that's going to be a good one. Your risk of outflow tract obstruction is X. So it was things that I didn't think about as a surgeon, brought by your cardiologist to try and improve the overall technique.
Yeah, I think it's fantastic. And I think, what, congratulations on pushing the envelope forward. And I think, I'm, like you said, I mean, this center is really well equipped to kind of push this agenda because of the
Yeah,
various expertises that we already have. So
I do. And that's what I think, the same thing. But there's the design flaws. Like, I don't understand why there's not a valve designed for this.
yes,
I mean, the sapien valve is too long, the skirt's too big. You could design and be working on the research and development for a design just like this. Like, we have the sutureless valve or the
yeah.
rapid deployment valve in the aortic position. Why are we not designing as teams the same thing for the mitral to be done through this incision? It's a tiny incision. The operation took about 2 hours. Like, it's not long, and you can get really good results. So, like, I agree, you talk about percutaneous mitrals, and I think they're great, but we spent a lot of time designing that valve and no time designing ideas like this.
So true. I really agree. All right, save some of that for Friday. That's fantastic. Corey, thank you for your time. I really appreciate it. You know what? It was an enlightening talk for everyone. And thank you, Sue. I mean, I'm sad that this is the last set of rounds that I'll be organizing officially. And I think, it's been a great experience for me and hopefully for you guys as well. And I'm so happy that, we had so many different people attend these sessions over the years. So thank you very much, Corey, and thank you to everyone for having tuned in. And I will put this on the YouTube channel, and all the best. And we'll see you soon.
See you soon. Perfect.